The Italian Committee for Bioethics decided to deal as the first topic during the pandemic crisis COVID-19, the topics of the ethical criteria in order to select patients when healthcare resources are scarce. It was really a big problem in Italy. As you know, there was a high percentage of ill people needing to have access to intensive healthcare settings and to have ventilators in order to survive. So there was a huge problem, above all in the north of Italy, to have ethical criteria for selection. Of course, the question of distribution of healthcare resources is not a new topic in bioethics. It is a chapter of bioethics. On macro level, so the so-called healthy policies, but also on micro level, so for the selection of patients. And this problem of selection is applied in many fields, for example, organ transplantation, but also in many emergent fields as disaster medicine, war, and also pandemia. That's why the Italian Committee for Bioethics decided to write this opinion. Of course, as we all know, we live in a pluralistic world. There are many different ethical theories about these topics. We all know there is the libertarian theory that focuses on the question of self-determination of patients, that doesn't recognize the duty of the state and the society to help the needy and help the vulnerable. So everything is left to the free market, to the liberal choice, giving the fact that the concern is about the minimum state and maximum market, without any guarantee of having access to healthcare facilities. On the other hand, we have the theory of utilitarianism, putting at the center the quality of life at just years. That is, the number of years to be lived by patients with a sufficient or enough quality of life, according to the cost-benefit analysis. In this sense, the criteria is the one of social usefulness. So, what's useful for society? Then there is the egalitarian perspective or personalist perspective, putting at the center the human dignity, intrinsic human dignity of a person, and the equality between human beings, and the application of equity with specific consideration for vulnerable populations. In the Italian Committee for Bioethics, as all the committees, we have a very pluralistic settings, not only on an interdisciplinary level, but also on ethical level. So there are many different theories inside. But we decided not to begin with an ethical theory, but to begin with the legal level. So in the framework of the Doctrine of Human Rights and Universal Declaration of Human Rights, putting at the center the principle of equality, and starting from the Constitution of Italy, that puts at the center the recognition of the dignity of a human being, of equality, and of a duty of solidarity, and starting also from the legal system, from the law that recognizes since 1978 the national health system, that is the universal access to health care, we decided that we don't need an ethics, because we have the ethics inside law, inside rights. And so, in this sense, this is the starting point, the equality. That's why in a situation as it was in pandemia COVID-19, I can say in the past, hoping it doesn't happen also in the future. So in that situation where healthcare facilities and healthcare professionals were not enough to cure and care about people, ill people, so we decided that in this specific situation we need the criteria for selection inspired to three main points. The first one is preparedness, the second one is appropriateness, the third one actuality. As regards preparedness, the discussion was about the necessity to have a balance between the public health, that is the health of all the society, and the health of a single individual. And so we need policies to make choices where there are responsibilities to be taken and to be traceable, and with a recognition that some decisions are extraordinary in specific circumstances but cannot become ordinary when the pandemic is no more there. Second point is the one of clinical appropriateness. So we decided with a majority of the members of the Italian Committee for Bioethics that the only really ethically acceptable criterion to select patients when healthcare resources are scarce is only the clinical one. That is, according to the severity of the illness, the urgency of a patient, considered case by case, the need, the clinical need of the patient, also considering the effectiveness, so the possibility of prognosis, of recovery. These clinical criteria that also, of course, include appropriate treatments, as all the treatments in the relationship between patients and physicians, is essential and needs to be put at the center. That means that age, sex, ethnicity, disability, responsibility for illness, a social position, all these criteria cannot be at the center of any decision. Otherwise, we will have discriminations. Otherwise, we violate the principle of equality between human beings. So age cannot be considered at the center of a clinical decision. Otherwise, we will have a discrimination. Only one member of the committee wrote a dissenting opinion, a minority report, and agreed with a document of the Society of Intensivists and Anesthesists in Italy, who wrote an opinion, this society which wrote an opinion about the criteria to select, and they said that age could be possibly be used as a criterion for selection, and not only that, this criterion could be considered as an a priori criterion to be applied automatically in the setting of selection. That is, we need to decide an age, and this age, it means that people, old people, couldn't access to the healthcare resources. So that was a minority report. It was only one person of the committee who wrote it. All the members, regardless of the ethical position, agreed that the clinical consideration, case by case, needs to be put at the center. It doesn't mean not to respect autonomy or not to respect the principle of care and cure of each patient, because a patient could refuse a treatment, and that must be respected and accompanied with palliative care. Possible advanced care directives need to be taken into consideration, and also obstinacy of treatment isn't allowed, as also in all clinical practice. Then the committee, the third criteria is the one of actuality. It means that the principle first come, first served cannot be used, but every physically present patient needs to be taken care of, so needs to be cured and cared. And the list of a community of patients, we called it the community of patients, also patients in sub-intensive care or patients at homes, but who suddenly become very, very ill, they need to be reconsidered in the list. So the list needs to be flexible because of the pandemic and because of the consideration of the need of the most possible number of patients that need to be cured and cared. Finally, the committee decided also to recognize the limit of responsibility of the physicians that had to decide in very few minutes or also in sometimes seconds to decide whom to cure and to care, and so a specific consideration for vulnerable patients. I want also to thank you for your attention, also on behalf of the chair of the Italian Committee for Bioethics, Professor Davak, who decided to participate to the conference, but it was not possible, and we decided to give this presentation in order, we hope, you will read our document, which is in our website. Thank you very much.